Hi everyone, and welcome to the North Zone review on capnography basics. I was able to get a PowerPoint presentation that was very kindly provided to us by Jerry from the South Zone, made a few adjustments for us, and added in a little bit of exciting information. So let's get going on it. All right, so I know a lot of us have done capnography review in the past, whether that be on our own time or when we rolled out the mainline capnography for our arrest patients in this zone. So hopefully this is just one big review for everyone, but if it's not, just follow along. We're going to make sure everyone is good and comfortable in this subject. As I mentioned before, this is a borrowed slideshow. I did borrow this from the South Zone. So while the term course objectives is still pretty relevant, to really make the point clear, I would rather call this slide things we need to understand to use capnography effectively. The equipment and the capability to take a capnography reading is only half the battle if you have no idea what you're looking at. So to have a full understanding of what we are looking at, we're going to cover these points listed here. We're going to need to understand the components or the phases of a capnography waveform. We're going to need to identify the normal and tidal CO2 range in healthy patients and unhealthy patients. We're going to need to identify when to use capnography in the pre-hospital environment. Which calls are we expecting medics to be using it on? We're going to want to be able to explain the benefits of waveform capnography in the treatment of pre-hospital patients. And lastly, we're going to need to identify specific capnography waveforms and their meaning. So what can a capnography waveform tell us? So let's get to checking some things off that list, starting with the capnography waveform and what it can tell us. Much like an EKG, capnography waveforms can have different nuances that can point to different processes happening with the patient's respirations and perfusion. So it's important to understand what each section of the waveform is representative of. It's important to note that all patients should ideally have a baseline of 0 millimeters of mercury and to return to 0 after each waveform. This is considered phase 1 of the waveform because it is that important to notice. If the patient's baseline is above 0, this is indicative of rebreathing, breath stacking, hyperinflating, whichever you want to call it. It essentially means that the patient is not fully expiring or fully emptying their lungs of carbon dioxide before beginning the next breath. Phase 2 of the capnography waveform is the expiratory phase. This feels a little backwards and causes some confusion when we're learning about capnography. Remember, we're measuring the amount of expired carbon dioxide, so it makes sense that this is when the waveform would begin to make an upstroke. The patient is expiring air into the sampler, causing the waveform to make a sharp upstroke where it will then plateau off. Phase 3 of the waveform is referred to as the alveolar plateau, meaning that the patient is coming to the end of their expiration. Plateau morphology can actually tell us some things as well, which we'll cover later, but for the sake of this slide, the plateau is going to be the part of the respiration cycle where the patient has finished passively expiring and is then preparing to start taking a breath. The point noted on this chart is the final angle of the plateau, and this is where we take our end tidal measurement from. Lastly, we have phase 0, appropriately named for where we want this waveform to end up. As I mentioned earlier, it's very important that everyone's baseline returns to 0. The patient has begun taking a breath in, causing a steep decline in CO2 all the way back to baseline 0. If it helps, you can think of your waveforms like a graph. Our vertical measurement is going to be our current amount of exhaled CO2, and the bottom measurement is going to be time. So now that we have covered the basics of the capnography waveform, let's go over how we're going to interpret those different phases of the waveform. So as I mentioned, the capnography waveform is much like an EKG waveform in the way that different morphologies can represent different symptoms. Just like an EKG would show us if a patient is hyperkalemic with a peak T wave, the morphologies of an end tidal waveform can do the same. These are some of the more common criteria that we're assessing when we're interpreting a capnography waveform. Of course, we're still going to want to treat our patient rather than the machine, as always. So with everything else, please use a high index of suspicion and a broad view of the whole picture. Does your patient's waveform look like what you expected it to look like? Is there a clinical explanation for what you're seeing from your patient and from the waveform? Are they matching? So just some of the things that we're looking for when we're interpreting, is there a regular waveform present indicating ventilation? Does every waveform look the same? Does the waveform return back to zero, or is there evidence of rebreathing? Just like we were mentioning earlier, we really need our patient's baseline to always go back to zero. Otherwise, we need to start looking why that's happening. Is the angle of the upstroke normal, or is there evidence of a slow expiration? Is the alveolar plateau normal, or is there evidence of uneven emptying or interruption of the expiratory period by inspiratory efforts, or clefs? We're going to get into that a little bit later. Are the end tidal CO2 values within normal range, and are they consistent with the patient's respiratory parameters? Again, with that, am I getting the numbers that I expected to see? Is the angle of the downslope normal, or is there evidence of slow inspiration or rebreathing? So to make this as easy as possible, we're going to go through some examples of commonly found waveforms in patients that we are making contact with in the healthcare profession. So let's start off with a normal waveform. A normal healthy patient's capnography waveform, their reading should fall between a range of 35 to 45 millimeters of mercury of expired CO2. It should have a uniform morphology, and it should have a consistent baseline of zero. This should align with a patient presenting as generally healthy or with minor complaints and compensating well. Even if your patient's waveform appears normal and healthy, it's still a good idea to get into the habit of running through your interpretation checklist. That was the list of questions on the previous slide. So let's do that right now. So first question, do we have a regularly occurring waveform present? In this one, it appears we do. We even have an appropriate number of waveforms in this 15-second strip that we can interpret our patient's rest rate. So we've got 4 waveforms in a 15-second time frame. So we're looking at about 16 breaths per minute, which is an appropriate range for that as well. Next, we're going to be looking at our baseline. Does our baseline return to zero with every waveform? And it appears it does. Is the angle of the upstroke normal? So in these waveforms, it does appear that the angle of the upstroke is normal. It's not sloped any more than usual, and it is starting from baseline 0. Is the plateau normal? Yes, in this case, it looks like the plateau is normal. It is mild. It has a mild upstroke angle. There's no dips in it. There's no clefts in it. It looks good. Are the end tidal CO2 values within normal range? We've already covered that, and it appears that yes, they are. They're falling just below 40 millimeters of mercury, which is perfect. And the last question was, is the angle of the downslope normal? So are there inspirations occurring normally? And it looks like for this waveform, they are. They are straight down to baseline 0, and I have no concerns with this waveform. So now that we've had the chance to pick apart the criteria of a healthy capnography waveform, let's look at some examples of not so ideal capnography waveforms. Let's start with an easy one. So this is a rebreathing patient. I know I've mentioned them a few times already. And what do we immediately notice about this waveform? Again, as I've mentioned a few times now, we always want our patient's baseline to return to 0, and that's the immediately striking part of this waveform is that there is a steady increase of the patient's baseline. It's not returning to 0. This is an important piece of criteria to look out for. And essentially what rebreathing means is that the patient is exhaling their CO2 and then immediately rebreathing it again. It's not something that you're going to see super often in the field, but that being said, we do know of a pretty good example of patients that rebreathe, and that is with our non-rebreather masks. If they're not set up properly with the O2 reservoir fully inflated, then that is putting the patient at risk of rebreathing their own CO2. So here is another example of a less than ideal capnography reading. In comparison to the healthy waveform I showed earlier, we can immediately see a big difference here. A hyperventilating patient can be presenting this way for a variety of reasons. So rather than getting into differentials, let's note what's different about this waveform. You can right away see that the waveforms are consistent in shape, but much narrower than the healthy waveform. This is because of the patient's high respiratory rate. This reading doesn't note an elapsed amount of time, but if we assume that it's also a 15-second snapshot, we can conclude that this patient's respiratory rate is approximately 32 breaths per minute, which is pretty high. You can also see that the patient has an end tidal CO2 of approximately 30, which is slightly below our healthy range of 35 to 40. This makes our patient hypocapnic while hyperventilating. The quick and easy explanation for this is that the patient's high respiratory rate does not allow a lot of time for gas exchange and results in the patient eliminating more CO2 than they are producing. And conversely, hypoventilation is going to give us a hypercapnic reading. This should correlate with a patient that's presenting with a low respiratory rate. You can immediately see the decreased number of waveforms in the reading. They're uniform, but what else is interesting about these waveforms? The length of the alveolar plateau is noticeably longer, indicating a prolonged breath cycle. The measurement of end tidal CO2 in this waveform is not terrible, but it is a little bit above our normal range. The patient is hypercapnic, which is the result of the body producing more CO2 than it's expelling with the decreased respiratory rate. So they're holding on to that CO2 rather than breathing it off. So as I mentioned a couple of times now, the morphology of a capnography waveform can be telling if you know where to look. Bronchospasm or lower airway obstruction caused by a variety of disease processes tends to be the most classic example of this, with its very distinctive shape of waveform, commonly referred to as the shark fin. I'm sure everybody's heard that terminology before. Bronchospasm can be represented by a sloping or slurred together of phases 2 and 3. And this is caused by the commonly long expiratory phases of patients who are air trapping and have to actively exhale. Breathing off is an active process for these patients. This creates a loss of the plateau while the patient is attempting to push air out until they absolutely have to inhale again. Additionally, these patients tend to be hypercapnic with their ability to exhale CO2 being compromised. And as we can see, this waveform is measuring an end tidal CO2 of well over 45 millimeters of mercury. Just to expand on the previous slide for bronchospasm, here is a realistic example of what we're potentially looking at in these patients. This is the capnography waveform of a bronchospasm patient prior to being treated. We can see that shark fin shape in the first few waveforms, and then possibly an attempt to compensate and breathe normally in the next few waveforms. It's not as, doesn't have that classic shark fin shape, but still an abnormal wave shape. What else do we notice about this reading? This patient actually appears to be hypocapnic based on this reading. Without actually seeing this patient and performing a full assessment, it's hard to say why this might be, but based off the reading alone, my biggest concern would be impending respiratory arrest due to severe bronchospasm that has progressed to the point of decreasing the patient's tidal volume and therefore their end tidal CO2. And here we have a much happier looking waveform reading. This actually appears to be the same patient post bronchospasm treatment, and we can see that they have had a significant improvement, at least in this parameter. The shape of their waveform is much better. They're much closer to the healthy end tidal CO2 range. From the looks of this reading, this patient is heading in the right direction, and we can conclude that the treatment is effective for them. Let's talk about troubleshooting end tidal. Like most of our equipment, an end tidal CO2 sampler can malfunction, but it's on us as the medics to know if we are dealing with an equipment malfunction or a change in patient status. Obviously, end tidal is not the only vital sign, the only piece of criteria that we're taking here. So this is where, we need to be preaching, treat the patient, not the monitor. If you have a sudden loss of waveform, but no change in your patient's outward status, then we need to figure out what kind of other issue that we're dealing with. Potential causes of this reading are numerous, but they're pretty easily troubleshot. They can include dislodgement of the device from the patient's face. So if your patient's nasal prong sampler has become dislodged from their nose, dislodgement of the tube from the defib. So the little orange portion that hooks into the defib, has that become dislodged? Dislodgement of your patient's advanced airway from their mouth. This could cause a sudden loss of a waveform as well. A little less likely, but respiratory arrest can result in a loss of a waveform. It's probably not going to be as sudden as this, but it's something to take into consideration and pretty easy to troubleshoot. And then cardiac arrest, which is also pretty unlikely, but I'm sure you're going to be a little nervous at this point, wondering what's going on with your patient. Luckily, this situation has another mnemonic for you to store away in your brain files. DOPE can be used to troubleshoot any common issues with a sudden loss of end-tidal CO2 waveform, starting with D. So we already talked about displacement. This could be either your sampling line or your patient's advanced airway. Check that everything is where it needs to be. Are any of your lines obstructed? Have your sampling lines or advanced airways become obstructed mechanically or with fluids? We know that especially patients in cardiac arrest, they can have quite a bit of fluid. Maybe they just need a good suction. Moving on to P, pneumothorax. Assess your patient's breath sounds and chest rise for possible pneumothorax. These patients will require decompression, which most of us cannot do. But it's obviously something that we need to know anyways, even if we can't do anything about it. E, equipment. So this is going to refer to checking that your equipment is attached properly and functioning appropriately. Check if your sampling line is properly connected to your Zoll, as we already talked about, and perhaps attempt to switch and re-zero your sampling line. Maybe you're having an issue with the zeroing. Running through this mnemonic should help you find the end of the cause of your end-tidal woes, and then you can carry on treating the patient. By now, I think I have managed to mention more times than I can count what a normal end-tidal CO2 range is for healthy patients. We can expect a bit of variance depending on a patient's diagnoses, but there is one outlying rule that we really need to cover. So when we're measuring our end-tidal CO2 in a patient that is actively being resuscitated, it's pretty fair to say we don't expect healthy levels. And we've been doing this in the North Zone for quite a while now, so we do know what we expect to see on these waveforms. We do expect that high quality CPR is going to produce a relatively normal waveform with a measurement of at least 10 millimeters of mercury. Between 10 and 20 would actually be the ideal. As I mentioned, numbers in this range are indicative of good, high-quality CPR, creating the best level of perfusion possible without a mechanical pulse. Anything less than 10 is considered to be an indication of either poor quality CPR or a likely poor outcome. This is some useful information to relay to OLMS should you be calling for advice on how to proceed with a resuscitation or a discontinuation of resuscitation. So in happier news, end-tidal CO2 doesn't just tell us when our patient's likely to have a negative outcome, it can actually also tell us when our patient has made an improvement. The picture shown here is illustrating the return of spontaneous circulation in an arrest patient. There is a sudden increase in perfusion due to a mechanical pulse returning. If you see this on the monitor while you're performing CPR, I understand it is pretty exciting, first of all, but please resist the urge to immediately stop resuscitation, finish your current cycle of CPR, and then go ahead and check a pulse on this patient, and you're still going to want to continue ventilating them as well. So speaking of capnography anomalies during resuscitation, let's talk about this little gem. The Curare cleft is the name for this small divot in the middle of our plateau phase. It's an interesting little anomaly with a whole complicated background of neurologic information. That's just basically going to boil down to your patient is attempting to spontaneously breathe through ventilation. The Curare cleft occurs when the intubated patient makes some basic effort to breathe on their own, essentially interrupting the flow of mechanical ventilation and creating a disruption in the flow of expired CO2. It's important to note that while this is a cool observation and good for the patient, And some useful information to include in a PCR and a handoff report. It's not an indication that you need to extubate the patient. Try and make a note at the rate at which the patient is trying to breathe, and then just continue to assist with your ventilations. It's very likely that your patient could not support their own ventilations at that point. All right, guys, buckle up. This is going to be a bit of a long one. I've kept this in here because I do think that it is crucial to our understanding of end-tidal CO2 and what it can tell us about our patients. When we think about waveform capnography and why we're using it in the pre-hospital setting, we tend to focus more on the respiratory complaints than anything else. But to understand capnography is to understand that not only are we measuring the effectiveness of ventilation, we're also measuring the effectiveness of gas exchange at the alveolar level. So what does this mean in simple terms? It means that anything that affects the exchange and distribution of oxygen and carbon dioxide in the body can have an effect on an end-tidal CO2 reading. So things like hypovolemia and heart failure can also leave clues in our waveforms to help point us in the right direction for treatment. Shown here, we have a waveform and we can see that this patient is having an exponential decrease in end-tidal CO2 as opposed to a sudden decrease. This can mean that we have a failure of the pump or the heart and a gradual decrease in perfusion. We can expect to see this in a patient who is becoming bradycardic as a result of heart failure, or possibly in a patient that is tachycardic to the point that preload and afterload are affected. This is also useful in our patients who have a medical or a traumatic bleed. Hypotension is now not the only indication of poor perfusion in our patients. If the patient is lacking the fluids to carry out gas exchange, then we're also going to see a steady decline in end-tidal CO2 as the patient loses volume. The point I'm trying to make here is that we can't limit our use of capnography to only our respiratory patients. Having a good understanding of how end-tidal CO2 is produced and measured can mean that this tool is useful to us in a variety of different calls. I'm not going to get hugely into this as it's being covered in another upcoming education session, but it does feel relevant to at least get a little bit into this. Before I move on, other possible causes of exponential decrease in end-tidal CO2 are going to be cardiopulmonary arrest or impending arrest, a pulmonary embolism, sudden hypotension or a massive blood loss, and a cardiopulmonary bypass. When we are talking about how capnography or end-tidal CO2 is measured and what affects our readings, we need to at least include a small blurb on VQ mismatches. The term VQ is referring to the ventilation and perfusion ratio in a person. It can be a bit misleading right from the get-go because it seems that ventilation and perfusion should have a 1-to-1 ratio. If you have good perfusion, then you should have, if you have good ventilation, then you should have good perfusion, which is not always the case. In a healthy person, we are looking at a VQ ratio of 0.8. This makes more sense when we take into account that not all areas of the respiratory system are participating in gas exchange. So these areas are referred to as anatomical dead space. I'm sure everyone has heard that term before. These areas include the mouth, the nasal passage, pharynx, trachea, bronchi. These areas hold room air, so we breathe in and we can hold air in these areas, but they don't participate in gas exchange. They don't push oxygen into the bloodstream. Therefore, a healthy person will ventilate or inhale more oxygen than they can distribute. So when we're faced with an abnormal end-tidal CO2 reading and we're trying to troubleshoot what the problem is, this is typically a good place to start. If our patient is not ventilating effectively, but so far is compensating with a good blood pressure or heart rate, this gives us a clue that we're probably looking at a low VQ ratio or shunt perfusion. The patient is not inhaling enough oxygen, even though they have all the fluid available to distribute it. As shown here, some examples of shunt perfusion would be an airway obstruction or a pneumonia where the patient can't bring in enough air to expand the alveoli, fill the alveoli, which of course means that there is no oxygen for the blood to carry. Conversely, if our patient seems to be ventilating effectively but still has an abnormal end tidal CO2, this is a clue that we are dealing with a high VQ ratio or dead space ventilation. The patient is inhaling all the oxygen with no fluid to participate in gas exchange and perfusion. This lack of fluid can be caused by volume loss, obstruction of those vessels, or even a pump failure, as we talked about earlier. The listed examples of this on this graphic are pulmonary embolism and cardiogenic shock. So hemorrhagic shock would also fall into this category because we have lost enough volume that there is now not enough blood to carry that oxygen around the body. All of this to say that end tidal CO2 has the potential to be a useful tool in all kinds of calls if we, the medics, don't place any limitations on it. So we're finally coming to the end of the didactic portion of this video, which is already probably longer than I was hoping it would be. In the interest of time, we can include everything in an educational video, so if you've reached this point and are still feeling a little bit unclear, here are some additional resources for you. The first is FoamFrat. Anybody who hasn't heard of FoamFrat, they have a great podcast and a website with some free resources. So I've already gone ahead and saved this free capnography workbook on our shared drive under paramedics and education. So you can head on over and take a look at that anytime you'd like. This workbook does go quite a bit more in depth with the anatomy and physiology, the chemistry, and it may help clarify any questions that you have. And of course, anyone that is set up with PAM now has access to Master Your Medics. There is a Mastering End Tidal CO2 course listed in the free resources, as well as several respiratory courses that have information on end tidal included in them. Lastly, most of us have seen this handout at some time or another, and it's still relevant and useful. This was done by our colleagues in, at the time, Prairie Mountain Health, or now the West Zone. It is saved on our shared drive under paramedics, education, equipment, and end tidal. I believe it's called end tidal package. Please utilize these resources. And of course, if you have any additional questions after reviewing these resources, you can contact anyone on the clinical team and ask your questions. Now let's get into some more exciting stuff. Why are we doing a capnography review? Coming soon to North Zone, trucks are going to be stocked with nasal prong and tidal samplers. So this means that our ability to obtain end tidal CO2 readings has expanded from just arrest patients to conscious patients. It also means that we needed to do a massive capnography review and ensure staff were proficient in this skill. So this video is going to be emailed out to all staff with some additional instructions. Please follow all of the instructions that are sent out with the video, and please do so in a timely manner. So before we finish this video off, let's do a little bit of a practical portion on the equipment that we are going to be carrying for our end tidal CO2 sampling on CAR. We already have our inline sampler, which is used during our cardiac arrests, and we are now going to be carrying a nasal prong version of a sampling line, which will be useful in any other patients that are conscious and don't require an advanced airway in place. So this sampler comes in the form of a nasal prong. It hooks up exactly the same as a regular set of nasal prongs. The only addition is that we have the little sampler here right underneath the patient's nose. So this is what is going to be collecting the sample and giving you the reading on your Zoll. The other thing about these sampling lines is they are, let's call them double lumen. They come with two lines that branch off from the nasal prongs. The first being the half that hooks up to the Zoll as your sampler. It hooks up the exact same way as the inline version. It goes in the side of the Zoll, give it a twist, and let it zero out before you then put it on your patient. The other line is actually an oxygen line. So if your patient is requiring supplemental oxygen, you can hook this up and deliver a nasal prong appropriate rate of oxygen to your patient. The other cool thing about these end-tidal CO2 samplers that I just recently learned is that they can actually be used in conjunction with our CPAP as well. So you can have this hooked up to your patient. Maybe they're declining to the point that they need CPAP, and we don't have to do anything really special with these. You can just put your patient's CPAP right over top of the nasal prongs. This shouldn't affect your CPAP seal. Um, and then, of course, it has the added benefit of being able to deliver extra supplemental oxygen without necessarily increasing the pressure for your CPAP patients, which is important if we're trying to avoid any of the adverse effects of CPAP. All right, guys, we made it. Thank you so much for watching. I know this video is probably a lot longer than I even hoped it was going to be. So again, thank you so much for paying attention, taking the time to educate yourselves on new equipment, re-educate yourselves on skills that we may have already learned in the past. And as I mentioned before, there's going to be some additional information coming out with this video in an email to everyone's work emails. Please follow the instructions in the email, and please read through the entire email for information on where we're storing this equipment and any other questions you might have. If you do have a question that is not covered in this video or in the email, you can reach out to any members of your clinical team and we will help you. Thanks so much, guys.